I think we should start. Good evening, everyone. My name is Egina Francis Makwabe. I'm the physician and nephrologist working with AHN, Africa Healthcare Network, as Chief Medical Director in Tanzania. I would like to welcome you all to our usual Thursday evening nephrology webinar. And today's series number 61. Today's topic is the new KDIGO Glomerular disease guidelines. And it's a great honor to introduce our today's speaker, Professor Jürgen Floege. But before I introduce him, I would like to read his short bio. Professor Floege is a distinguished fellow of the ERA-EDTA and recipient. Professor Jürgen Floege is the head of the Division of Nephrology at the University of Aachen, German since 1999. He's a former executive council member of ISN, ERA-EDTA, and KDIGO. He is a recipient of the 2018 ERA-EDTA Award of outstanding clinical contribution to nephrology. And until April 2020, he was the president of the German Society of Internal Medicine, Europe's largest professional medical society. Together with Professor Richard Johnson, Marcello, Tonelli, and John Feehally, he edits the best-selling textbook, Comprehensive Clinical Nephrology. And I should also admit, Professor, that this is like my my Bible. I always read this book almost every day. I have the soft copy and the hard copy as well. Professor Floege is a co-chair of the new KDIGO Glomerular Disease Guidelines Committee. And finally, Professor Floege is associate editor of Kidney International since 2018. And previous associate editor of nephrology, dialysis, and transplantation. Research interest encompasses progression of renal disease, in particular renal fibrosis, immune-mediated renal disease, in particular IgA-nephropathy, as well as bone and mineral disorder, CKD-MBD, and cardiovascular disease in uremic patients. His scientific work encompasses more than 650 original papers, reviews, and editorial. Professor Floege, it's a great honor to welcome you, and welcome, and please proceed with the presentation.
I'm always amazed when somebody reads my CV and wonder whether that is me or somebody else. So I'm from Aachen, Germany, and I'm very certain that will not mean anything to anybody. But this is my funny hospital. This is actually the hospital. This is our helicopter landing pad, and you can see these hills back in there. That is already the next country. That's the Netherlands. And if you were to look a little here, that would be Belgium. So I'm in a very funny location in the center of Europe. And it's actually where Germany was founded 1,200 years ago. So it's a very historic city, but this, of course, is not pretty historic. Anyway, so today's topic are the new KDIGO practice guidelines on glomerular disease. They were published about a month ago. And this is how it all started. Actually, this is a picture back from 2017, 4 years ago. We gathered almost 100 people, all experts in glomerular disease. And we simply asked the people, could you please look at the existing guidelines? You remember the first guidelines were published in 2012. And tell us, where do you need updates? Everything that has a green tick needs an update. And you can see that there's almost nothing in the 2012 guidelines that did not need an update. So that clearly told us there's a lot of work to do. and we will all have to put in a lot of effort. And very frustratingly, in a way, this is how the guideline evolved. It started in 2017 with this controversies conference. We had several meetings. There was a guideline draft, a public review, a journal submission, and finally, just about a month ago, it was published. It almost takes 4 years for a guideline to be published, but, and I believe you will see this and feel it, this is by far the largest guideline that KDIGO has ever published. So all you junior people, when somebody asks you to chair the glomerular disease guidelines, if you have a lot of time, say yes. If you don't, it will be difficult. And I can tell you this is a lot of work. So the guideline, as we have it, starts out with a Cochrane review. So we hired the Cochrane group in Australia, and they did the PICOT questions. So the existing population intervention comparator outcome study design. They define, or we agreed on, what are critical outcomes, let's say mortality or need for dialysis or 50% loss of GFR, and what is important, but not absolutely critical. And this is what we then asked, do we have clinical trials in this outcome region? And just to give you an idea of how much work went into this, they screened more than 20,000 citations for randomized controlled trials, and they found, which is nice to see, they found quite a few randomized controlled trials, most of them in vasculitis, lupus, and nephrotic syndrome in children, and IgA-nephropathy. Very, very, very few in anti-GBM. So we had a mixture of super rare diseases with almost no evidence and diseases where there was good evidence to guide us. And then almost 500 randomized controlled trials and 102 additional studies formed the basis of this guideline. And the Cochrane group then came up and ranked each study by how certain we are. That is there a low risk of bias or a very high risk of bias? And they did lots of data analysis and finally came up with a plot like this, where they simply ranked each study. Does it, in this case, an IgA nephropathy study, does it favor combined corticosteroids and RAS blockade, or does it rather favor RAS blockade alone? And this is what the actual guideline looks like. We have 2 levels of evidence. Level 1 is we recommend. Most people in your situation would want the recommended course of action, and only a very small proportion would not. Level 2 is much weaker. We suggest. The majority would want the treatment, but many would not. It's a little more ambiguous. And then each level is graded. Are we very confident? Or is it very low level? The estimate of effect is very uncertain and often will be far from the truth. And it's important to memorize this because we have a lot of level 2 recommendation and relatively few level 1 recommendations, as is typical for kidney disease. Whereas my cardiology friends, they all have level 1 recommendations, and they're very certain because they have lots of trials. A new feature in the 2021 guideline are practice points. Initially, when KDIGO started, they wanted to base everything on randomized controlled trials only. And they quickly realized we have so few that it was very difficult to make recommendations. So we argued that, well, maybe we should add practice points. Practice points are not guidelines. They are just advice of the expert group. For example, there will never be a randomized controlled trial on whether a kidney biopsy should be evaluated by light microscopy plus immunohistology, etc., or when to do a repeat kidney biopsy. It just seems we can guide you and help you making a decision in these practice points. But I stress, these are not guideline recommendations. This is what the final work looked like, and you can read it freely on the web, be it through the KDIGO website or be it through the international, Kidney International website. It's in the October 2021 issue of Kidney International, and this is only the 60-page executive summary. The full guideline is several hundred pages, and they are in an open access Kidney International supplement, which you can also read freely on the web. The guideline is huge. These are the diseases covered. So we have a summary, of course, then we have general principles, then we have the most common glomerular nephritides. We have a large chapter on infection-related glomerular nephritis, with actually very few randomized controlled trials. We have what used to be the membranous proliferative chapter, and now we've gone to the term immunoglobulin and complement-mediated glomerular diseases with an MPGN pattern of injury, realizing that, like focal sclerosis, MPGN is mostly a histology pattern and not just one disease. And then we have the three major systemic diseases, but we had to make cuts somewhere. So for example, Alport is not in here. Some hereditary diseases are not in here. But even with those cuts, the guideline is massive. So let's start with chapter 1. A practice point. If you want to access total urinary protein excretion in patients with glomerular diseases, a 24-hour urine collection should be obtained. We still recommend that. When feasible, it's a pretty good compromise to collect an intended 24-hour urine sample and then measure protein-creatinine ratio in there. The beauty of that approach is you tell your patient, please collect the urine for 1 day, but it doesn't matter if they forget a little bit or if they add a little bit too much because they didn't listen. Because you measure the ratio in there. Now, why is it important to measure the ratio? Or this is in children. In children, we still admit the first morning sample is appropriate. But this is a nice illustration, in particular, if your patient is very proteinuric or nephrotic. This is a nice illustration why it makes sense to collect the urine over a day rather than using spot urines. This is an old study, more than 30 years old, where patients were put in bed, they had a constant diet and they were off medication, and they repeatedly measured in spot urine samples the protein creatinine ratio. Now, in the middle of the day here at 12 noon, if you see the patient, you would say, oh God, this patient is proteinuric as hell, 9 grams per gram. You see that same patient again early on the third day, and you say, oh, wonderful, proteinuria is decreasing. And you see how, in particular, in very proteinuric patients, spot urines can really be misleading. And they may tell you that your disease is getting worse or better, when in fact nothing has changed. and the average would always be 5 grams. Another practice point is that we should use lifestyle modifications in all GN patients as a synergistic means of controlling hypertension and proteinuria. I see a lot of patients with IgA nephropathy for second opinions. And they come to me with the question, oh, my doctor said I should get high-dose cortisone therapy. And in walks somebody like that, massively obese. And I always ask the referring physician, what is the likelihood I cure obesity with corticosteroids? It is not there. So I rather tell that patient, hey, you need to lose weight, which is easy for me to say because I'm not obese. And I realize it's not easy to lose weight for many patients. But clearly, this is a factor that is overlooked frequently, which has major implications for blood pressure control, for anything. Patients should be counseled to restrict sodium intake to less than 2 grams per day. That would be 5 grams of sodium chloride. So that's a fairly restricted diet. And in some countries, like in Germany, it's very hard for patients to follow that because they need to start and bake their own bread. They cannot go to a bakery because German bread is very rich in salt. Dietary protein restriction may be considered in adults, but we are cautious here. You don't want to go into malnutrition at the same time you don't want to have protein excess. I have stopped using allopurinol in patients without gout. You know, there was a discussion that uric acid is a progression factor for kidney disease independent of gout. But after these 2 large studies published in the New England Journal, both of which were negative, I have stopped lowering uric acid unless my patient has gout attacks. Now, let's focus on the glomerular nephritis types, which are most frequent in Europe. I realize that things may be different in Africa, but most diseases that you probably see a lot of have very few randomized controlled trials. So IgA nephropathy, if you see a patient like that, we say in a practice point that clinical and histological data at the time of biopsy can be used to assess the risk. And there's a prediction tool, which you can find in this website. It's only for IgA nephropathy, for no other diseases. And say that there are no validated prognostic serum urine biomarkers. This is the risk prediction tool that you can use to assess the risk for the about 6 years that follow the biopsy. Considerations for treatment of all patients. And I believe this is in the IgA section because we felt it's very important for IgA, which is a very slowly progressive disease, but it's in reality, it's true for every glomerular disease. The primary focus should be optimize supportive care, assess cardiovascular risk and commence appropriate intervention, give lifestyle advice. So when I see a patient with IgA nephropathy, I go over this list of things. And I believe this is a list which is true for every glomerular disease, including diabetes, including hypertensive injury. So we suggest to control blood pressure with a sitting BP in the 120s. We suggest to up-titrate ACE inhibitors and ARB. I have stopped using the combination, but I rather up-titrate them. I avoid dihydropyridine type calcium channel blockers for the simple reason that a dihydropyridine type calcium channel blocker opens up the preglomerular vessel, so you transmit the pressure into the glomerulus, whereas the ACE inhibitor or ARB will open up the postglomerular vessel, so you will lower the pressure in the glomerulus. I advise my patients on diet. I advise my patients on all components of the metabolic syndrome, including, and I find that a very important recommendation, including what is good sport and what is bad sport. For example, I see with IgA, it's not uncommon to see young men. Some young men are into weightlifting. If you have ever measured the blood pressure of a professional weightlifter, it can go up to 350 millimeters mercury, 350 millimeters mercury. So I tell all my patients, you can do any endurance sport, swimming, walking, jogging, cycling, anything, but don't do weightlifting, at least not with heavy weights. It's probably underappreciated in kidney disease. Aldosterone antagonists, if there's a suspicion that my patients no longer respond to RAS blockade and have aldosterone breakthrough, smoking. If you have glomerular disease and you smoke, you are crazy. Your risk for dialysis increases 6-fold if you smoke in IgA-nephropathy. So it's a very potent progression factor, most likely via hypertension. Every time you have a cigarette in your mouth, your blood pressure increases by 10 to 15 millimeters mercury. You don't feel that, but your kidneys will. Here's the first recommendation, a very strong one, 1B. So we are very confident of this. We recommend that all patients with a proteinuria above 0.5 grams per day, irrespective of whether they have hypertension, are treated with a RAS blocker. This is very important, irrespective of hypertension, because in some countries, in particular in Asia, you cannot even prescribe a RAS blocker if there is no hypertension. And very clearly, there's good evidence that people with glomerular disease often already have a small degree of higher blood pressure, even though you wouldn't call it hypertension, just because they have glomerular disease. A 2B recommendation, we are much less certain, is that patients who remain at high risk despite all these measures I told you, they are considered for 6 months of corticosteroids, and we must discuss the risk of toxicity. Several studies, including one of ours, have killed patients with immunosuppression. In particular, if the GFR is very low, if there's diabetes, if your patients are obese, if there's latent infection, secondary disease, etc. So I have become very, very hesitant in using high-dose corticosteroids. And this is one of the trials. We did the Stop IgA trial several years ago, and this is the long-term outcome. And you can see that at least in Germany, for my patients, it did not matter whether they received supportive care only or supportive care plus immunosuppression. The outcome after 10 years was almost identical. So very clearly, lifestyle measures and supportive care, good blood pressure control is key in IgA nephropathy. Let's switch to membranous glomerulonephritis, where I think we all agree that the identification of autoantibodies against phospholipase A2 receptor was a breakthrough. And that clearly was one of the reasons why the guideline needed an update, because it wasn't even discovered when the first guideline was published. So here's the first practice point. Use clinical and laboratory criteria to assess the risk of progressive loss of kidney function. Same as in IgA nephropathy, same as in almost any glomerular disease. And these are the 4 categories in membranous glomerular nephritis that we identify. So low risk is your patient with normal GFR, non-nephrotic proteinuria, and almost normal albumin. The opposite is the patient with very high risk, life-threatening nephrotic syndrome, rapid loss of kidney function not otherwise explained. And then there's 2 intermediate categories, depending on proteinuria to a large degree, normal GFR or reduced GFR, but also depending, and this is new, on the titer of your autoantibodies. If you have very high titers, you are immediately at higher risk. The first 1B recommendation for patients with membranous nephropathy and at least 1 risk factor for progression, we recommend using rituximab or cyclophosphamide and steroids for 6 months, or tacrolimus for 6 months, with the choice of treatment depending on the risk. And this is what we recommend. A very low risk patient, wait and see. There's no need to treat them if they have 2 grams of protein in the urine and good GFR. If there's very high risk, we only recommend cyclophosphamide using the famous Ponticelli regimen. And we do so because this is the only treatment that has been proven to retard dialysis. And this is good news for many countries in Africa, because obviously this is the cheap treatment. Whereas rituximab is very costly, even though we now have biosimilars, it's still a very costly therapy. And calcineurin inhibitors alone would only be used in moderate risk. And I go back to this. So only if there's a normal GFR and modest proteinuria. One of the trials that has been very important for this guideline is the Mentor trial, where they compared rituximab or cyclosporin in the treatment of membranous nephropathy. And they used 2 infusions of rituximab, 1 gram on day 1 and day 14. If you look at 12 months, the cumulative incidence of remission is very similar with both. But then rituximab-treated patients did much better and maintained remission, whereas most of the cyclosporin-treated patients went into a relapse. But this is a comparison of apples and oranges, and it's not fair. It is not fair because treatment ended at 12 months. And clearly, when you stop treatment with rituximab, your B-cell depletion will still go on. It will go on for another 6 to 12 months. Whereas cyclosporin will stop working 2 days later and you get into the relapse. So the fair comparison would have been to continue cyclosporin, but this is what the trial was designed as. The more important comparison is, should I use cyclophosphamide or should I use rituximab? Is one of them better than the other? So this is the famous Ponticelli regimen, 3 months of oral cyclophosphamide and 1 month of corticosteroid. So you have a 6-month therapy, 3 months with cyclophosphamide, and then month 2, 4, and 6 is the corticosteroid month. And this was compared in Italy. And this is what it looks like. It is not different. Proteinuria decreases in both patients groups very similarly. The albumin is very similar in increasing. And these treatments are identical over the 3-year period and just as effective. And the important thing is there was no difference in adverse events. Some of us believe that rituximab is the better choice, and we have concerns that cyclophosphamide is so toxic. No, it is just the same at least in this study in Italy. The only concern I have with the cyclophosphamide is the long-term risk of cancer. But remember, this is a fairly low dose. If you have the Ponticelli regimen once, you have a cumulative dose of about 10 to 15 grams, which is below the threshold where we see a lot of cancers coming up. A practice point, if you can measure the phospholipase A2 autoantibodies, use that to guide your treatment. The autoantibody levels change much faster than proteinuria. And you can use the response of the autoantibodies after 3 months to guide your treatment. If they quickly fall, you will need no additional rituximab. You can withdraw cyclophosphamide, or you let your patients continue on the calcineurin inhibitor. And then you do it again if you can, and again, use it to guide your treatment. This is a new concept in membranous nephropathy. Minimal change and FSGS. Here are some recommendations for children with nephrotic syndrome. First, we recommend that oral glucocorticoids be given for 8 weeks or 12 weeks. This is then a lower dose regimen of alternate day glucocorticoids. We're fairly confident. If you have frequently relapsing or steroid-dependent nephrotic syndrome, and you're currently taking alternate day glucocorticoids or you're off, we recommend that steroids are given again in episodes of respiratory tract infections or other infections for 5 to 7 days to reduce the risk of relapse. So cover them during the infection. And finally, if you have children with frequently relapsing nephrotic syndrome who develop side effects, we recommend sparing agents. This could be oral cyclophosphamide, levamisole, MMF, rituximab, or calcineurin inhibitors, rather than no treatment or continue on the glucocorticoid. Here's a recommendation in minimal change in adults. We recommend high-dose oral corticosteroids for initial therapy in adults with minimal change disease. If there are contraindications for corticosteroids, use any of these. So essentially, it doesn't matter. You can probably use anything. The other recommendation is to use cyclophosphamide, rituximab, calcineurin inhibitors, or MMF if there's frequently relapsing of corticosteroid-dependent minimal change. Now, this may change in the next update of the guideline because there are now 2 studies comparing a corticosteroid-based approach with a calcineurin inhibitor-based approach. And this is a British study where they compared 25 patients on tacrolimus twice daily versus prednisolone starting at 1 milligram per kilo per day. And you can see that achieving a complete remission after half a year is identical. I must say, if it were me, I would probably prefer tacrolimus over prednisolone starting at this very high dose. And they then tapered the disease. And the bad news is that when you taper, you probably relapse. And you can see that after 1.5 years, only 20% of the patients remained in remission. But again, both treatments were similar in efficacy. And importantly, the adverse event rate was comparable. So there's no treatment which is clearly better, and the choice is up to you. In children with minimal change, we recommend using cyclosporin or tacrolimus, initial second line, if you have steroid resistant nephrotic syndrome, and this is of course often then FSGS rather than minimal change. And these are general advice we give for these children in terms of indications for biopsy. If you can, genetic testing for bone protection, for gastroprotection. And I will not read all this to you, so please look it up on the website where you can see the full text. FSGS in adults. When you find FSGS on the kidney biopsy, and I'm stressing not FSGS in the context of another disease, any disease in the glomerulus can lead to FSGS. If you only find FSGS and you have nephrotic syndrome with nephrotic proteinuria and low albumin, then this is likely primary FSGS, and this patient will likely require immunosuppression. If there is no nephrotic syndrome, or even the proteinuria in the non-nephrotic range, then evaluate for an underlying cause, exclude secondary and genetic forms, and only if nephrotic syndrome develops, consider immunosuppression. And the recommendation, if you consider immunosuppression, is again to use high-dose corticosteroids. ANCA-vasculitis. This is the general scheme that the patients would probably go through. You make the diagnosis of ANCA-associated vasculitis. You assess the extent of the disease. You try to induce remission. Ideally, you get the disease under control. You go to maintenance therapy, and then one day you decide to go off. The guidelines recommend that you should use corticosteroids in combination with cyclophosphamide or rituximab as initial therapy to induce remission. For maintenance, we recommend either rituximab or azathioprine and low-dose glucocorticoids. If there is no organ-threatening involvement, consider methotrexate. For the kidney world, this is not relevant because I never use methotrexate in kidney disease patients because of the dosage problem. And if there is very, very severe involvement with life-threatening disease, consider adding plasmapheresis. Plasmapheresis, in this large study, the PEXIVAS trial, 704 patients, 20% with pulmonary hemorrhage, 20% on dialysis. They compared plasma exchange versus no plasma exchange and high-dose and low-dose corticosteroids. And plasma exchange was not effective. It didn't improve outcome. Yet still, we are uncertain if you're very, very ill, whether to do it or not. And I still do it in some of my patients. The important finding of that study is, though, that it didn't matter whether you give 1 milligram per kilo of steroids or half the dose. And the good thing is that if you give low-dose corticosteroids, you have a 30% lower risk for serious infections. If you look at the doses in the low-dose arm, let's say you have a 70-kilo person, you go down fairly quickly, and after 11 weeks, you're already, so that's good news that you can probably save some infections by using low-dose corticosteroid. Lupus nephritis. Here's a recommendation, and that's true for any lupus nephritis. If you see lupus nephritis, give them hydroxychloroquine, unless it's contraindicated, which is very rare to be contraindicated. If your kidney biopsy shows class 1 or 2 lupus nephritis, the extra-renal manifestations of lupus should guide the immunosuppression. If there's nephrotic syndrome, you likely have something like minimal change disease, and you should treat as minimal change. Most frequently, we see class 3 or 4 lupus nephritis. And there we recommend that all patients with active class 3 or 4 lupus, independent of whether they have a membranous component, should receive corticosteroids plus low-dose IV cyclophosphamide, the so-called Euro-Lupus scheme, or mycophenolic acid derivatives. And after completion of initial therapy, we recommend maintenance with mycophenolate mofetil. In class 5, we recommend RAS blockade, immunosuppression guided by extrarenal manifestations if there's low level of proteinuria. If there's nephrotic syndrome, we recommend immunosuppression with essentially any of the agents. And of course, as I said earlier, everybody should be on hydroxychloroquine. So I believe that's my last slide. And I would be very happy to answer any questions, and thank you all for listening to me.
Thank you, Prof. That was excellent talk, Prof. Thank you very much. And yeah, so it's a time for questions and answers. And Professor is ready to listen to the questions. Prof, when you are preparing, I mean, when you are working on the guidelines, you use Cochrane with the PCOS, population intervention comparator outcome. But I can see randomized controlled trials, more than 50% were from IgA-nephropathy.
Yeah.
And some other guidelines, I mean, some other diseases were very few. So how did you come up with guidelines while some other diseases were significantly low numbers that were found during the study?
This is bad news for you, very bad news, in fact. For example, on malarial disease, we have almost nothing. There's not a single randomized controlled trial. And in the infection-related glomerular disease chapter, you will find mostly practice points. And we felt it's important to make practice points because we have no randomized controlled trial to develop guidelines. So you're all encouraged to embark in randomized controlled trials. So I see quite a few questions on in the chat. Should we go over these?
Yes, Prof. Yes, Professor.
Okay,
Please.
so one question is, if I use a RAS blocker in non-hypertensive patients, do you watch the patients to go to hypotension crisis? Well, yeah, sure. I tell my patients, watch out for your blood pressure. If you get dizzy when you stand up and it's too low, if this happens briefly once a week, it's still okay. If this happens every day, forget it. You need to lower your dose. What is high and what is low corticosteroids? Good question. Usually high dose corticosteroids would be 1 milligram of prednisolone per kilo per day. So 70 milligrams in a 70 kilo person. Low dose would be anything below 20. Where, of course, side effects are lower. Another very important question, and a very tricky one. How do you stop treatment in ANCA vasculitis, and when do you do it? Are the titers useful? Yeah, I would be hesitant to finally stop maintenance therapy if I still have high titers of ANCAs. If the titer is stable and low, and if I have maintained maintenance therapy for 2 or 3 years, often it's my patients telling me, hey, why don't you take me off? Do I have to take this forever? And often I agree. We have no good guidelines to tell us when we can stop. 24-hour urine protein is better than PCR. What about UACR? That's a tricky question. KDIGO in general recommends albuminuria measurement because albuminuria is much better standardized than proteinuria. But in glomerular world, in glomerular diseases, if we were to switch to albumin creatinine ratio, we have no literature to base our recommendations on. Protein and protein creatinine ratio is still what all the trials have. Maybe in 10 years, we have enough data to switch to albumin, but until then, we recommend proteinuria rather than albuminuria measurements. And the 24-hour urine, as I said, is often better in glomerular disease because in proteinuric glomerular disease, you have a very extensive circadian change and swings that can be misleading. ACE and ARBs in IgA-nephropathy, how do you advise these? Stopping RAS blockers at a GFR below 30. Don't do it. Keep them in the system because there's now many studies that have shown that cardiovascular events are much more common if you stop RAS blockers below a GFR of 30. And even going into dialysis, it's more common if you stop them. So I maintain my RAS blockers until patients are in dialysis. And the only thing to watch out for is potassium. And I use loop diuretics to control for that. Here's a question on multi-target treatment for lupus nephritis. Well, this is a Chinese concept. And I usually don't use it. I use only MMF. And I believe the evidence that this works better than any of the existing therapies in Caucasian or African patients is very slim. Can chloroquine substitute for hydroxychloroquine? I have no experience with that. I always use hydroxychloroquine, but I would assume that chloroquine works just as well. But if there's anybody in the talk, in the audience who knows better, please correct me. Wonderful presentation, thank you for that. Can we use CNIs alone without rituximab in membranous nephropathy? Yes, you can. I would not combine it with rituximab. And if you want to use it in moderate risk, that is not the patient who is on the way down with the GFR who's very nephrotic. If there's only moderate risk, yes, you can. We should not use non-dihydropyridine. No, wait. There's an important typo. You can use non-dihydropyridine calcium channel blockers. So verapamil and diltiazem are safe. Whereas things like amlodipine, nifedipine, nitrendipine, they will really transmit the pressure into the glomerulus. So I use dihydropyridine calcium channel blockers in hypertensive patients with glomerular disease only as third line. Choice number one is a RAS blocker. Choice number two is a diuretic. And if you then still don't have your blood pressure under control, then you can add amlodipine or nifedipine, but don't use it as first-line agent. Another tricky question, how long do you maintain patients with lupus nephritis on MMF? Honestly, I don't know until my patients ask me. And of course, when they're very quiet, and they have no complement consumption any longer, and the anti-nuclear antibodies are stable. After 2 to 3 years, I try to taper them off. Any place for azathioprine in minimal change or FSGS? I don't really believe so. It's not very effective. Lifestyle modification, fish oil. We no longer recommend it in the guideline. I don't use it. And your wife will hate you if you use fish oil. because you smell like a dead fish. And also note that some fish oil preparations are very rich in cholesterol. So watch out what you're using. Can you please support the use of biosimilars? Yeah, we do use it. I hardly any longer use rituximab. I use a biosimilar and it's just as good. So no reason to not use this one. And here's another question on RAS inhibitors over calcium channel blockers. Is there a threshold in GFR that precludes it? Yes. I would not start a RAS blocker if my GFR is 10, because then my patient may end up on dialysis. But as I said, RAS blockers are very, very protective for heart and kidney, even at a GFR below 30. And I would rather lower my GFR to 25 and protect my patient than not using a RAS blocker for concerns about a GFR drop. Next question. Thank you. Thank you. In setting of absent kidney biopsy, corticosteroids or calcineurin inhibitors? Well, I don't really know about children. There are no good trials. But in the adult who's nephrotic, I think you can use a calcineurin inhibitor, because if it's minimal change, it's okay. If it's FSGS, it's okay. If it's membranous, it's okay. Actually, in membranous, calcineurin inhibitors are better than corticosteroid monotherapy in adults. Children may be different. Here comes a case, 12-year-old child with nephrotic range proteinuria, blood and casts, BP stable. I don't do biopsy, can't afford. I suspect FSGS could be, yes. As I said, if you have access to a calcineurin inhibitor, this could be one of them. Otherwise, start a corticosteroid. Is proteinuria micro or macro a determinant of whether RAS blockers should be used? No. RAS blockers, yes, I agree. Blacks have lower renin levels, but still the mechanism of action of a RAS blocker in blacks is the same. You have post-glomerular vasodilation, which should protect the glomeruli. The concept of not using a CCB in IgA, is it applied to other glomerular diseases? Not yet. But let me stress again, I'm not against using a calcium channel blocker. I don't use them first line. My first choice is a RAS blocker. And I guess that also answers the next question. What about the concern of cystitis when cyclophosphamide is used? Yeah, maintain a high fluid intake. Give your patient Messner if you have it. But the important thing is maintain a high fluid intake, in particular in a hot country. And a young female with lupus nephritis desire to bear children. Oh my God, yeah, that's a terrible question. Can cyclophosphamide be substituted with MMF in stage 3 or 4? No. MMF is an absolute contraindication if your patient wants to become pregnant. And you shouldn't become pregnant for several months after being off MMF. Wow, you have many questions, but good questions. Thank you for them. Remission protocols for various glomerulonephritides. That's a huge question, and I would really ask you to have a look at the guideline for the specific disease you are thinking of. Okay, any more questions?
Okay, Prof. Yeah, can you please proceed? I've seen someone asking questions.
Here's a very important other question. CNIs in the absence of lab monitoring, tricky. very tricky. I mean, most patients will have a fairly standard dose of tacrolimus or or cyclosporin. But if you can measure them at least occasionally, it will be important. Remember that, for example, cyclosporin is fat-bound and lipophilic, and there are profound disturbances of cyclosporin in severely nephrotic patients. But if you really don't have it, rather than not treating, I guess you will have to make a compromise and treat them.
Okay. Question, Prof. Thank you very much for a refreshing talk on glomerulonephritis. Now, there is something always, I mean, what I could call a nephrologist's nightmare, which I expected you to mention about. That is glomerulonephritis with the crescents of whatever cause. Can you? I mean, I thought you would tell me maybe what specific approach. Now, next, the other question is, you mentioned rituximab and cyclophosphamide as of being maybe ecotoxicity, but what do you think if the patient is of childbearing age? Because again, the other nightmare is knocking somebody's gonads, actually, being male or female with cyclophosphamide. Now, is it also the same risk with rituximab? Because this part of the world I have come, we don't use rituximab quite commonly. Thank you very much.
The line was a little bad, but correct me if I'm giving a wrong answer. First issue, crescents. I always argue that a crescent is not a nightmare in itself. You have to look at the clinical picture as well, and in particular at how quickly your patient loses GFR. And I'm saying that on the basis of data from IgA-nephropathy. They did kidney biopsies in patients with isolated microhematuria, nothing else, no protein in the urine, normal GFR, and they find crescents in some of these patients. Single crescents, but they find crescents. And it's logical that you find crescents in somebody with microhematuria because you have a break in the GBM. And if you have ever seen what a parietal cell of Bowman's capsule does when they meet blood, they proliferate like crazy. So the therapy in that patient is lower blood pressure and give them a RAS blocker to lower the glomerular pressure, and the crescent will disappear. The situation is different when you find 50% of your glomeruli with crescents, and when the GFR goes down very quickly, when you have true rapidly progressive glomerulonephritis, then you need to do something. And usually the therapy would be cyclophosphamide or rituximab plus steroids. But again, let me stress that the clinical picture is a complete picture of histology and laboratory findings. If you see a crescent in the presence of a stable GFR and low proteinuria, lower blood pressure, that is not an indication for intense immunosuppression. Now, the other question, if I understood it correctly, was the female with cyclophosphamide and fertility. Yes, that is a concern. And yes, if I can, I always use rituximab in younger patients, in particular if they want to maintain fertility. The risk is not very high that you induce amenorrhea with 10 to 15 grams of cyclophosphamide, but it's real. I agree. It's a concern. And it depends on the choices you have.
Thank you.
Thank you, Prof. We'll take one more question before we allow Prof to go and rest. Any other question? Dr. Lloyd, do you have any question?
The dose of CNI, the levels that does it go according to the transplant levels, or would it go different from much lower than the transplant levels?
Super question, and I can tell you we had a half-day discussion on this in the guideline group. There has never been a trial testing different levels in glomerular diseases, and we just assume it has to be like the transplant situation. That's all we can conclude on this. Nobody has ever tested this. There's an old study where they tested extremely high doses of cyclosporin in nephrotic patients because, as I said, the pharmacokinetics is very different if you have a cholesterol of 500. But that has never been really pursued. So in the absence of data, we still recommend the transplant levels in glomerular diseases and not anything lower.
Thank you so much.
All right. Thank you very much, Professor.
It's been a pleasure.
A great presentation.
Yes.
And yeah, we really appreciate it. And we Africans here in Africa, we enjoyed your presentations and would love to have you again next time, Professor.
I would be happy to do that.
The knowledge.
Yeah.
Thank you, Prof.
Okay,
so
bye-bye, everybody.
Yes, right.
Thank you very much. And I think we had a maximum audience today, so we had some instability in the system. So thank you very much, Professor. It was a wonderful session.
Thank you. Bye-bye.
Bye.
Bye-bye. Thank you. Bye.
Thank you.